The topic is nasogastric tubes. We're going to talk about insertion, suction, and removal. Nasogastric tubes, we commonly call them an NG tube in practice. They can be a single or a double lumen. The tube is inserted through the nose, down the esophagus, and then into the stomach. Indications for an NG tube include providing enteral nutrition. We're talking about tube feeding there. So someone who's not able to eat for a temporary amount of time, whether they be sedated and ventilated, or they've had some kind of surgery on the head and neck, and they're not able to eat, they can have enteral nutrition through an NG tube. Also, gastric decompression, used for something like a small bowel obstruction, where the contents of the stomach are not able to move down through the intestines. The stomach gets distended, they're very uncomfortable, and we need to remove those gastric contents. So we put the NG tube down there and we can decompress their stomach that way. Another reason for it is gastric lavage. You're very rarely going to see this. It's usually in the emergency department when someone has ingested something and they need to remove it from the stomach. Maybe they've overdosed on a medication, so they put the NG tube down, they'll remove the stomach contents and then rinse it out. That's what that lavage means, you wash it out. Contraindications include a facial or basilar skull fracture. We mean a fracture at the base of the skull. If that's towards the front of the skull, it can actually cause a problem if you insert the NG tube through the nose. You may end up with that tube entering the area of the fracture. You could put it in the brain. So absolutely, we want to make sure there's no fractures of the face or the skull when we're putting in an NG tube. Also, esophageal varices, those distended veins that happen around the esophagus for someone who has cirrhosis. Because the blood can't move through the liver, it backs up, and those veins around the esophagus become distended and they're very fragile. So if we put an NG tube down there, we could end up puncturing one of them and end up with a bleed. Also, if they've had surgery on their stomach, some kind of gastrectomy, you may not want to put a tube down there. So check with the provider. Next, let's talk about NG tube insertion. So the first thing you want to do is, of course, gather your supplies. I always make sure I have a cup of water with a straw. My patient's going to hold that, and have some paper tissues for them to hold as well. Other things you need, the tube, of course, and then you're going to need some lubricant, lots of lubricant. And then also the first thing you do before you start is make sure you have your tape ready, because your hands are going to be full and you're going to need your tape to secure the tube. Make that tape ready before you start here. Let's get started with step one. First off, you're going to measure the length of NG tube that you need to insert. And here we're just estimating. And the way you're going to do that is by taking the very end of the NG tube and holding it against the tip of the nose. And then you're going to go along the tube with your other hand and find the length to the earlobe. And then next you can let go of that part and then hold on to where it is at the earlobe, and then go down the tube and find the length down to the xiphoid process at the bottom of the sternum. And that's going to give you your estimate of how much tube you need to get to the patient's stomach. Hold on to it down here and mark it with some kind of marker so that you can keep in mind how far you want to push that tube down. Step number two, you're going to lubricate the tip of the tube. Be generous here. 3 to 4 inches of the end of the tube, make sure it's well covered in a water-soluble lubricant. This is uncomfortable. You're putting the tube into the person's nose. They've probably never had something pushed into their nose before, so you want to make sure you have lots of lubricant to help ease the passage of the tube. Step 3, so go ahead and take your tube that's now lubricated, and then you're going to push it through the nose and start to advance it through the nasal passage. Use a gentle rotating motion. It's bumpy in there. You need to find the path of least resistance. So you're going to gently rotate and feed it towards the back of the throat, and then stop when you get to the back of the throat. Step number 4, here's when your patient gets involved. So when it gets to the oropharynx is when we're going to have the patient tilt their face downward. This is when they're going to start to sip on the water. The idea here is that that swallowing motion as they sip is going to help to close the epiglottis. What we don't want is that NG tube slipping down into the trachea. So as they swallow, the epiglottis covers that part of the trachea, so it can't go down. Instead, it's going to go through the oropharynx, down into the esophagus, and then the stomach. And we know we're going to hit the gag reflex as we move through the back of the throat. If you notice your patient is choking or gagging, go ahead and withdraw slightly. That may mean we're in the wrong spot. And then give them a second to breathe. Catch their breath. Make sure they're not in respiratory distress. Give them a second, and then start attempting to re-advance the tube until you can get it all the way down. Once you have the tube fully inserted to that mark that you have on the tube, so you know it's in all the way, you're going to go ahead and temporarily tape the tube, and we're going to talk about how to do that in a second. Next up, you're going to verify placement via x-ray. Nurses who have practiced a long time, you'll see this sometimes. They'll try to do like maybe the pH test on some of the contents, or sometimes they'll do this funny thing where they push some air in the tube and listen to the stomach. These things aren't evidence-based, but you may see them. Follow your facility policy, but always make sure you're getting the x-ray. You have to confirm placement that way. Last step, you're going to make sure the NG tube is secured and that marking is at the nares. Let's talk about how do you secure the NG tube. So what you're going to see primarily in practice is tape. There are some manufactured devices like a bridle. It's a soft string that's going to go in through the nose, behind the septum, and come out the other side of the nose, and then have a little clip. And that's a really secure way to do it. And there's no tape on the nose. You see it a lot in the ped setting. But what you're probably going to do in practice is at least start out with the tape. So how do you keep this tape secure? You'll see this done in lots of different ways, and you'll see nurses who take the tape and they wrap it around the tube over and over and over again, but it doesn't really do much because one of the most important pieces is making sure it's secure to the nose. So it needs to be secure to the patient's nose and it needs to be secure to the tube. So how do you make that tape? And we talked about making your tape before you even start this whole procedure. So we call it the little pants method. So I've got a little piece of paper here. Pretend like this is a piece of tape. Use good tape, use like a silk tape. A paper tape is not gonna work here. So you got your silk tape, you got your little piece here, and we're gonna do the pants method. So we're gonna take our scissors that we have in practice, and we're going to cut upwards until we make some very long pants for a very tall person. And so then we have our main chunk up here. We want to make sure we have a good size square, and then we have two little pant legs here. You're going to take that, let's say that this is my nose, this is my NG tube. You're going to take the square at the top, put it on the nose, make sure it's secure. And then what's nice is that these little legs can go ahead and wrap around your tube. So you'll wrap it, tape it, and then you'll wrap it the other way and tape that to the bottom. So you got it secure at the nose and secure on the tube, and that's what's going to keep it there. And make sure you keep checking. You assess this over and over again, every shift, every time you go in the patient's room. Patients are going to sweat. The oil on their skin is going to make that adhesive turn into goop, and it's just going to slide right off their nose. So keep an eye on that. Let's talk about NG tube intermittent suctioning. So this is what you're going to use when you have gastric decompression. So let's go ahead and look at the device a little bit. You see there's the container there. It's called a suction apparatus. That's what's going to catch all the gastric contents that are coming out of the NG tube. And then, of course, there's going to be another short little tube that's not here that goes to the wall device. That's what controls the suction through the vacuum through the wall. Then you've got your long tube coming off of the suction apparatus, and that's going to connect to the actual NG tube going into your patient. Here we're talking about a double lumen NG tube, and that's what you're looking at in the picture here. A double lumen means that throughout the length of the tube, there's two openings that are running parallel. So here you see two openings on that tube. The clear piece is attached to the adapter. That's the main part of the tube. That's where the gastric contents are being removed. You also see that blue piece. That's the other opening, and that's the air vent. This is really important when we talk about gastric decompression, because as you have suction coming out of the stomach, you can end up sort of like, imagine when you're taking a trash bag out of a trash can and it just won't move. You have suction in there. So what we need is for air from the atmosphere to be able to move in and out of the tube. That's where the air vent comes in. So it means that we can help prevent just this intense suction inside the stomach without air moving through, because we don't want to damage the gastric mucosa, the lining of the stomach, by having suction just sitting there. So let's remember that that air vent always needs to stay open. Sometimes you'll see people want to clamp it because every once in a while it can have a little bit of drippings of gastric contents coming out. Don't clamp it. It has to stay open. It's a safety feature. It's there to protect the gastric mucosa, and it helps prevent that excess suction. Another thing to think about with this is it's intermittent suctioning. That intermittent is an important word. The suction goes in intervals, and this also helps protect the gastric mucosa. And this is something you have to pay attention to with the device on the wall. You should be hearing and seeing the suction go up, and then it'll go for a little bit and then come back down. That dial is going to move for you, telling you the intensity of the suction, because it shouldn't be continuously going like we would with a chest tube or something. And that's your responsibility. Make sure it's on the right setting. It needs to be intermittent. Let's talk about NG tube complications. One of the things you worry about the most is vomiting with an NG tube, because we definitely don't want our patients to aspirate. This is something you want to monitor for and treat. If you think about it, the nasogastric tube, as it goes through the esophagus, and then it goes into the stomach. That esophageal sphincter that's supposed to prevent things from coming out of the stomach can't close all the way because the tube is in there. So we have to be especially careful for monitoring for gastric contents coming upwards. So we want to make sure we're managing the nausea. If someone is having nausea, again, the NG tube decompression is meant to fix their nausea by emptying their stomach. So if they're having nausea, that may mean the tube is either obstructed, it's not placed properly, or the suction's not enough. Other complications, gastritis or gastric bleeding, that would come from irritation from the tube being in the stomach. Also, nasal pressure ulcers. Think about this the same way of like a medical device staying on the skin for a long time, same thing. It's in there on the nasal mucosa or on the skin around the nares. You can end up with necrosis if that tube is just putting a lot of pressure on a certain area for a long amount of time. This is also why if they know they're gonna have an NG tube in for a long time, they'll sometimes go with a thinner, more flexible tube. This is easier to stay in there for a long time. It's not as irritating to the tissue. Another potential complication that comes with tube feeding specifically is clogging of the tube feeding. Here we talk about over and over again, flushes are your friends. You want to be flushing a tube that has feeding going through it. Feeding has sugars in it. All these carbohydrates can get sticky. The worst thing that can happen for your patient is if their tube gets clogged from tube feeding because we haven't been flushing it enough, and then they have to have the whole tube replaced. You never want to be the nurse that says, I'm sorry, I got to pull it out and put it back in. So make sure you're keeping the tube open if you're doing tube feeding by flushing it. It's sort of like you're eating a meal. You need to take sips of water to keep things clear in there. NG tube removal. Let's talk about taking that tube out when the patient's ready for it. First off, you want to make sure the patient's in high Fowler position. We're going to have the tube come out. There's going to be some fluids coming with it. We want to make sure they don't aspirate. And then when you get ready to take out the tube, go ahead and talk to your patient, let them know what's happening, and bring a towel with you because like I said, there's going to be some fluids coming out too. You're going to instruct the patient while you're removing it to hold their breath. This helps to close the glottis, that part that helps protect the trachea, because you don't want those little fluids coming out to go down into their throat. They end up with pneumonia from this. So we instruct them to hold their breath. This closes the glottis, protects their trachea, and then you're going to remove it in a single smooth motion. Like if it's not, just keep pulling till the whole thing comes out. You don't want to stop partway through. And then place it on your towel. Go ahead and have a towel on their chest, because this tube full of secretions is coming out and it's going to be drippy. Next up, you're going to observe whether or not the tube is intact. Go ahead and check it out, make sure a part of it hasn't broken off somehow, and then make sure you're documenting the procedure.